Symposium. May I please request the people sitting in the back to fill in the chairs in front.
चलो चालू कर दी तो बोल के देते हैं
Without much ado, I'd just like to welcome the chairpersons for the session. Dr. B.T. Dharmanan, who is the IRA Indian Rheumatology Association President, Consultant Rheumatologist in Bangalore, and Professor Devashish Nanda, who is the President of the APLAR and Professor at the Crystal Medical College of Bangalore. To take over the proceedings from here on. Thank you.
इनको लेते हुए इनको लेते हुए खाली सेंटर वाली स्कीम इसका फ्रेम
Good evening, welcome everyone. I now invite Dr. B.G. Dharmanan, the President of Indian Rheumatology Association, to give a word of introduction to the session.
Good evening. It's a great privilege to be the part of this wonderful symposium. We have speakers from all the continents of the world assembled by our own APLAR president, and this is one of the unique features of this Iracon. And we have President of Australian Rheumatology Association with us today. Welcome you, sir, on behalf of Indian Rheumatology Association. And with this, and we have beautiful speakers and wonderful topics to be presented today. I hope and wish all of the speakers are here today due to COVID restrictions and various reasons. Many of them were not able to make it live today, but they have agreed to present their paper online today. And what you present, sir?
Thank you, Dr. Dharmanan. I can see that Dr. Doug White, the President of the ACR, and Dr. Zifa Day from Ghana, the President of AFLA, and I'm sure Dr. Anna Maria will also join soon. She is having the Italian rheumatology meeting right now. So I welcome all of you. And we have three of the speakers still with us in person. Professor Takeuchi, the President-elect of APLAR, and Dr. Sam Whittle, who is the President of the Australian Rheumatology Association, and we have Dr. Carlos Enrique Toro from Colombia. Traveled all the way, full circle of the earth, he came down here, and he's there as a PANLAR Secretary General. So welcome everybody. Without wasting any time, Dr. Doug White is online, and his talk will be presented now. Go ahead, please. I would like to introduce, while the talk is being loaded, Professor Douglas White is a professor and he works in the Gulistan Health System and in the USA in the rheumatology department. He is also been associated with the Wisconsin University Health System. So I now would like the organizers to start the presentation of Dr. Doug White.
Hello, Iracon. This is Doug White. I am a rheumatologist in Wisconsin in the United States and the current president of the ACR. I would like to express my sincerest gratitude to Dr. Danda and Dr. Vadika and the other organizers of Iracon 22 for this wonderful opportunity to join you, albeit virtually. My sincerest regrets that I was unable to make the trip to Indore. I genuinely hope to have the opportunity to do that sometime in the not too distant future. I don't have any financial disclosures for this talk, and as you are well aware, I'm here to talk about Convergence 2022, the recent American College of Rheumatology meeting that just completed in Philadelphia, Pennsylvania last week. As has been the case for a couple years now, we started off Convergence with the Global Rheumatology Summit. This was a virtual conference with over 800 participants. The content is still available on demand if you're interested. The faculty who were presenting represented 19 countries across the globe. And we started off with a keynote symposium on the global impacts of climate change, conflict, and migration and their effects on human health and disease, with some really outstanding presentations and a panel discussion by representatives from the United Nations, Jamaica, and Doctors Without Borders. The Convergence 2022 meeting in Philadelphia was also very well represented by research, original research originating in India, and I provide this partial list for your perusal if you would like to investigate some of these abstracts in more detail in the future. Today I'm going to try to provide a summary of some of the studies from Convergence 2022 that I hope may have an impact on your clinical practice. Specifically, we'll talk a little bit about some of the studies around preclinical rheumatoid arthritis, lupus, cancer screening, and idiopathic inflammatory myopathies, some options for steroid-sparing agents for polymyalgia rheumatica, new data about holding methotrexate and mycophenolate following vaccinations, and a new approach for trying to reduce the immunogenicity of pegloticase for therapy in gout. I will start off with a couple of abstracts relating to this concept of preclinical RA. Of course, I'm talking about this long period of time before patients who develop rheumatoid arthritis have evidence of autoimmune disease systemically and in the joints before they develop something which we start to suspect is going to turn into RA, and certainly before they develop a disease which is classifiable as RA. And I think this scheme is important because it's forcing us to ask some very fundamental questions about rheumatoid arthritis, like what causes rheumatoid arthritis, whether or not we can predict, especially among those patients who we identify as having a positive CCP, who's actually going to get rheumatoid arthritis, and most importantly, can we prevent the development of rheumatoid arthritis, again, most importantly in those patients that we can see ahead of time by virtue of their positive CCP antibody status. So one of the studies that addressed this this year at ACR 22 was presented by Duncan Porter, abstract number 535. He's from Scotland, and what they measured was community infection rates, here shown as infections per 1,000 patient years, in undifferentiated arthritis and rheumatoid arthritis, and they graphed that or displayed it relative to the onset of their disease. So here you can see the community infection rate in asymptomatic patients before they get rheumatoid arthritis, in the symptomatic period before they're diagnosed with rheumatoid arthritis, and then in the early arthritis period. And what you can see, of course, is that the infection rates are higher in the patients than in the controls. The thing I liked most about this poster was a very straightforward and clear-eyed hypothesis statement pointing out the fact that it's not as simple, and we can't simply assume that there's a causal relationship between these infections and the development of arthritis. And it's certainly not necessarily as simple as infections promote the progression of autoimmunity, but there are a number of other very plausible explanations, including antibiotic therapy in patients who have infections changes their microbiome, and perhaps that promotes autoimmunity, or perhaps there's some reverse causality in the sense that their systemic autoimmune disease is associated with an impaired ability to defend themselves against infections. And finally, the possibility that the two are unrelated, and it's independent factors like smoking and lung disease which predispose people to both rheumatoid arthritis and infections. Another trial that I think is worth mentioning was came out of Leiden in the Netherlands, abstract number 266. And in this presentation, they showed results from the Leiden clinically suspect arthralgia cohort. And they were comparing the cytokine profiles from patients who turned out to progress to get inflammatory arthritis, and compared that to the cytokine profiles in patients who did not progress to get an inflammatory arthritis. And what they noted is really that there was no significant change in gene expression over time for a large number of cytokines. The results are shown here. The print is kind of small, I apologize for that, but the take-home message is that in the patients who progressed to develop inflammatory arthritis here in the top box, all the lines for all the different cytokines that they measured are flat. They didn't change over time between the baseline measurement and the time of development of the inflammatory arthritis. They did find some, what I would classify as relatively minor differences in a few cytokines, including GCSF, CCR6, and TNIP1 in the patients who did not progress, but I would consider those pretty minor and only in a few cytokines. So I think the take-home message for me for this abstract is that by the time the patients develop clinically suspect arthralgias, the cytokine profile is already set and doesn't change much beyond that point. Another study that I thought was interesting and worth noting was abstract number 533 presented by Dr. Wilson from the University of Colorado. They studied 66 patients, all of which had a positive CCP, but no inflammatory arthritis. And they hypothesized that if rheumatoid arthritis has its pathogenesis in the lung and other mucosal sites, perhaps if they studied sputum for antibodies against CCP or rheumatoid factors, they might be able to narrow down and better detect patients who were going to go on to get rheumatoid arthritis. So they tested induced sputum in these patients and then monitored them over 1 to 5 years for the development of rheumatoid arthritis or inflammatory arthritis. And sure enough, they identified that the presence of sputum antibodies predicted the development of arthritis. The results are shown here. They had 2 cohorts, a derivation cohort and a validation cohort. The results were the same in both cohorts, so you can just look at the graph over on the right, which shows the combined cohorts, where you can see that in the Kaplan-Meier curve, the RA survival was substantially less, the RA-free survival was substantially less in the patients that had these antibodies present in their sputum compared to patients whose sputum was negative for the antibodies. So perhaps this will turn into a clinically relevant way to further narrow down which patients are actually, with a CCP, are actually going to go on to get rheumatoid arthritis. Is there something we can do in this early preclinical stage to treat patients and prevent the development of arthritis? There have been a number of studies along these lines, and one of the abstracts that was presented this year in Philadelphia was abstract 530. This is the 12-month extension of the ARIA study. Their 6-month results were previously shown, in which they demonstrated that patients treated with abatacept were more likely to show an MRI response than patients treated with placebo. They demonstrated that even off therapy at the 12-month point, these results were extended. Again, the MRI responders were higher in the abatacept group than in the placebo group. But the trial that probably got the most attention in all of the studies at Philadelphia this year was the STOP-RA trial. This was presented by Kevin Dean at the University of Colorado. And as you may have already been aware, this was an attempt to prevent the development of rheumatoid arthritis in patients with a positive CCP. So they studied 142 patients, all of which had a positive CCP, but no history of inflammatory arthritis, no prior DMARD use, no inflammatory arthritis on their exam. But they didn't pay any attention to symptoms or imaging findings, as has been the case in other similar studies. They gave these patients 1 year of hydroxychloroquine versus placebo and then followed them for 2 years. And what they observed was that both groups, regardless of whether they received hydroxychloroquine or the placebo, developed rheumatoid arthritis at the same rate. Approximately 35% of these patients developed rheumatoid arthritis. The 2 arms of the study were indistinguishable. Here you can see the patients treated with hydroxychloroquine in the blue line and the red line representing the placebo, and the orange box at the bottom illustrating the period of time during which the treatment was administered. Their conclusions from this interim analysis of their STOP-RA trials that individuals with this positive CCP and without inflammatory arthritis at baseline, they were unsuccessful at preventing or delaying by providing a year of hydroxychloroquine at the beginning of the study, and therefore this study was halted due to its futility. This set the stage for this year's great debate titled "To Treat or Not the Role of DMARDs in Subclinical Rheumatoid Arthritis." And I think if you watch the debate, you'll see that this is still very much an open question, but one of my favorite parts about the debate was this beautiful table presented by Dr. Dean outlining many of the studies that have attempted to treat this group of patients those with a positive CCP or some other degree of indication that they are at risk for developing rheumatoid arthritis, and then the variable success or failure to delay the onset or prevent the development of arthritis. You can see these are studies that have included treatment arms with dexamethasone, rituximab, atorvastatin, methotrexate, a couple studies with abatacept, and most recently the STOP-RA trial with hydroxychloroquine. The other thing that I think is useful to note from this table is that across these studies we're seeing over a few years time period the development of rheumatoid arthritis in approximately 25 to 45% of the patients. And I think that's a useful clinical number for us when we identify these patients and try to discuss with them their risk of going on to develop an inflammatory arthritis. Switching gears now to systemic lupus erythematosus. This, of course, is a topic that's been generating a lot of interest over the last few years within the United States. A tremendous increase in the number of drugs that are approved, especially for treatment of lupus nephritis. Last year at the ACR meeting, voclosporin got a lot of attention, but we've seen a much bigger pipeline than just voclosporin developing with studies looking at the timing of the available therapies, sequential therapy, enhanced B-cell depletion, mouse studies with dual BAFF and APRIL blockade, and then other agents like this thalidomide analog and an antibody that targets plasmacytic dendritic cells, as well as an IL-2 mutein and another agent that blocks TLR7, not to mention an ongoing trial with secukinumab. Well, this momentum was carried into 2022, and there has been a lot of notable work in the literature this year in terms of lupus, including Dr. Fury's trial with enhanced B-cell depletion, the iberdomide trial in the New England Journal of Medicine, the anti-dendritic cell trial published in the New England Journal of Medicine, CAR T cells with T-cell receptors against CD19, published in Nature Medicine, and then a very interesting study in Nature identifying a TLR7 gain-of-function mutation as a monogenic cause of lupus. But I want to focus on the three abstracts above that were presented in Philadelphia, as I think they probably have the most impact on our clinical practices in the near term. The first has to do with the rates of transition of cutaneous lupus to systemic lupus. This is abstract number 338, presented by an internal medicine resident named Dr. Yang at the Mayo Clinic. He and his colleagues studied 324 incident cases of cutaneous lupus. These are patients from 27 counties in the upper Midwest in the United States. Their cutaneous lupus and eventually their systemic lupus was identified using ACR and EULAR criteria. They excluded cases with prior or concurrent diagnosis of lupus, in other words, within 90 days of the diagnosis of cutaneous lupus. And then they followed these patients until they were diagnosed with lupus, or until they died, or until they emigrated out of the study area, and observed an 11.8% transition rate over 20 years. Here you can see these data presented with the cumulative incidence of lupus over time. And importantly, they discovered, or they confirmed, as had been seen in other studies, that younger cutaneous lupus erythematosus patients, especially those below the age 40, were more likely to go on to transition to systemic lupus, as well as patients with subacute cutaneous lupus erythematosus were more likely, compared to patients with other forms of cutaneous lupus like discoid lupus, were more likely to transition to systemic lupus. A very interesting trial out of the University of Wisconsin presented by Dr. Garg and her colleagues, including Christy Bartels, in abstract 344, gave us some very important information about therapeutic windows with hydroxychloroquine and the expanding use of blood testing in hydroxychloroquine used to not only identify patients who are not adherent, but to make sure that their dose is correct. What they did was they studied 166 samples from patients on hydroxychloroquine, and they abstracted data about their dose and their socioeconomic and demographic factors, their SLEDAI scores, their kidney function, their insurance coverage, something called the deprivation index, and social barriers to care. And then they also asked those patients about their medical adherence. And what they were able to identify was some relationships between different medical factors or characteristics of the patients and their blood levels of hydroxychloroquine. first and most important is that levels of hydroxychloroquine between 500 and 1,000 nanograms per ml were negatively associated with active lupus as measured by a SLEDAI score greater than or equal to 6. And they also identified CKD as being associated with levels of hydroxychloroquine in the blood above 1,500 nanograms per milliliter, which is considered to be supratherapeutic. So giving us some key insights as to target therapeutic windows and levels of hydroxychloroquine that we will want to pay attention to and pursue in the future in our patients with lupus. The last study that may not have immediate relevance for your clinical practice, but I think is coming down the pipe perhaps faster than some of the other therapeutic agents out being studied currently, was presented in abstract number 1000 by Dr. Catlett. And this is a phase 2 trial examining the use of deucravacitinib in patients with lupus. This, as you are probably already aware, is an oral selective allosteric inhibitor of TYK2 related to the Janus kinases. TYK2 is upstream of type 1 interferons, as well as IL-23 and IL-12. It's previously been studied in psoriasis and psoriatic arthritis, and in Philadelphia, they presented the results of a phase 2 trial in 363 lupus patients who received either placebo or one of 3 doses of this new TYK2 inhibitor. And these patients were then followed over 48 weeks. Here you see the main results of their trial, where you can see all of the blue and green lines represent the different doses of the TYK2 inhibitor, and the gray lines represent the placebo. You can see that in general, the patients who received the study drug had a nice response in terms of peripheral lymphocytes and neutrophils and complement, and some of the antibodies, including anti-double-stranded DNA antibodies, also went down. There's a general recognition that it's relatively easy to look good in a phase 2 trial, and we'll see how this pans out in further studies when we get some more clinically relevant markers. But I think this is one to keep your eyes on moving forward. Another trial another presentation, I should say, that got a lot of attention this year in Philadelphia was one of the plenaries. This was plenary number 2, and this was Dr. Olroyd from Pittsburgh presenting a scheme for thinking about how to screen for cancer in patients with newly diagnosed idiopathic inflammatory myopathies. So their suggestion and their presentation was about taking 3 steps when you approach these patients. The first being identify whether or not they have risk factors that put them at low risk for going on to develop a malignancy, or intermediate risk, or high risk, and you can see these risk factors listed on the slide. Secondly, they divided the investigations for looking for cancer into 2 groups. There's a basic screening group and an enhanced screening group. And then thirdly, they combined these into a suggested scheme for when and how often to screen patients and how to screen patients for cancer. So, for instance, you can see in the left-hand side in the red boxes, if you identify a patient as being high risk, as identified by 2 or more high-risk factors, they recommend basic screening at the time of diagnosis, followed by continued screening at 1, 2, and 3 years after the onset of their myopathy. They also recommend, in this group, enhanced screening at the time of their diagnosis. And in contrast, over on the right-hand side, in the low-risk group, in patients who do not fulfill criteria for either high or intermediate risk, they suggest just the basic screening at the time of diagnosis. So they're the first to point out that the scheme has not been validated, and rather their intention is to try and start a conversation and give us a starting point, not only for assessing clinical utility of such a scheme, but also to develop future studies to try and determine the statistical validity of such a screen, and hopefully someday the cost effectiveness of these various approaches. So I look forward to this developing over time and applaud them for their efforts in terms of giving us a scheme and a starting place. Next, I wanted to talk quickly about the ongoing saga of steroid-sparing agents, trying to identify steroid-sparing agents to treat patients with polymyalgia rheumatica and giant cell arteritis. As you are all well aware, this is a story that goes back a number of years now, including early trials with etanercept and other TNF inhibitors in patients with PMR and GCA. Those didn't produce very favorable results, but that was rapidly followed up by the JIACTA trial demonstrating the utility of tocilizumab in patients with giant cell arteritis. That was followed quickly by another study by Carol Langford's group at the Cleveland Clinic looking at abatacept and its favorable effect on patients with giant cell arteritis in terms of reducing their need for prednisone. And then recently at EULAR, we saw the SAFFR study with another IL-6 blocker, cerulumab, and those positive results. This year at ACR 2022, we saw the results of 2 more studies, both of them in patients with PMR. This is the Semaphore and East PMR trials. One of them studying tocilizumab, again, the IL-6 blocker that we currently use in the United States for patients with GCA, and extending to a new mechanism of action in the East PMR study to look at tofacitinib, one of the JAK inhibitors. So I'm going to show you quickly the results of those trials. The first was presented in abstract number 1106. This is tocilizumab in patients with PMR. They studied 101 patients with persistent PMR requiring at least 10 milligrams per day of prednisone. They treated these patients with tocilizumab at the higher dose of 8 milligrams per kilogram IV and compared them to placebo treated patients over 24 weeks. And what they observed was that the patients who received the tocilizumab group had lower disease activity and less glucocorticoid use. So the primary endpoint shown in the bars on the left is a composite endpoint of their CRP PMR disease activity score and a decrease in glucocorticoid use. And then you see those results broken out. The percent of patients who achieved these results are shown in the y-axis, with tocilizumab being shown in the yellow and compared to the placebo group in the green. So promising study for the extension of tocilizumab, not just from GCA, but also into patients with PMR, perhaps if they need it and perhaps if it's economically viable. That was, of course, one of the main questions after this study, is whether or not we really need a biologic agent in PMR to the same degree as we do in GCA, where the courses of corticosteroids are so much more prolonged and associated with much higher morbidity and even mortality. Another study presented by Dr. Chen in abstract 1107 addressed the efficacy and safety of a JAK inhibitor, tofacitinib, in patients with PMR. Their approach was slightly different. They looked at 52 patients with a new diagnosis of PMR and immediately randomized them to receive either tofacitinib at 5 milligrams twice a day or prednisone at 15 milligrams per day with a scheduled taper. They monitored their disease activity as well as a couple of inflammatory markers, their ESR and their CRP. And they noticed that the patients treated with tofacitinib responded just as well as those with prednisone. I think the important graph here is over on the left, where we're seeing the disease activity scores for PMR, and you can see the patients treated with glucocorticoids had a nice response, as you would expect, and the tofacitinib treated group had a very similar response. We saw similar responses in the inflammatory markers. I think this is very encouraging, and hopefully this will lead to further study of the JAK inhibitors in this important group of patients. Another topic that got a lot of attention, which I think is highly relevant to our practices, is the concept of how long should we be holding DMARDs following vaccination. An important study here was presented in abstract 936 by Dr. Park. This is from Portland, where they studied 178 patients who were on stable doses of methotrexate for rheumatoid arthritis. These patients were given a quadrivalent seasonal influenza vaccine and then randomized to hold their methotrexate for either 1 or 2 weeks after the vaccine. They observed that both groups had an equal vaccine response, indicating that you only need to hold the methotrexate for 1 week. And importantly, they also detected a slightly increased risk of flares in the group who held their methotrexate for 2 weeks. So here is the vaccine response. We're looking at patients who held their methotrexate for 1 week in blue compared to patients who held their methotrexate for 2 weeks in red. And you can see the number of antigens that they responded to, as well as their antibody titers, were highly comparable between those two groups. And then this is the flare data. And what you can see here is in this graph with the DAS28 flare rate measurement, there was a slight increase in the number of flares in the patients who held their methotrexate for 2 weeks compared to the patients who only held methotrexate for 1 week. So this is going to inform our practice in my clinic in terms of asking patients or suggesting to patients that they hold their methotrexate for 1 dose following their seasonal influenza vaccine. And by extrapolation, we're applying the same thing to some other vaccines as well, and hopefully we'll get more data along those lines as time goes on. Along those lines, there was also a nice abstract 797 that looked at 220 patients who received SARS-CoV-2 vaccines. These were exclusively mRNA vaccines from Pfizer and Moderna, and then they collected up clinical information, including whether or not the patients had held their methotrexate and whether or not their disease activity flared through an electronic questionnaire. And what they observed, as you might expect, was that the patients who had a high antibody response against the vaccine were more likely to have held their mycophenolate for more than 10 days than those who had held their mycophenolate for less than 10 days. Through the questionnaires, they also identified that there was no significant increase in the rate of disease among the participants who held the mycophenolate either for short periods of time or longer periods of time. I think this is the kind of study that will prompt further investigation and perhaps look at disease flares and adherence through other means besides an electronic questionnaire. But again, encouraging information that it is possible to hold some of your DMARDs immediately following a vaccine without severe consequences in terms of disease activity and with really important results in terms of the ability to enhance the antibody response following the vaccine. Last thing I wanted to talk about quickly was another study that is informing us how to use pegloticase, which is getting more and more use, I would say, in the United States at least. It's still pretty expensive, but there's a cohort of patients, at least here, with just really severe gout, highly capacious gout, which we're having difficulty controlling with more routine uric acid lowering agents. And now that we're learning how to use pegloticase more safely, it seems to be entering clinical use more commonly. So this is a study actually from 2 years ago at the ACR 2020, where they showed that pre-treatment with mycophenolate reduced the rate at which patients developed an immune response against the pegloticase and therefore enhanced the activity of the pegloticase over time. This had been tried in the past with azathioprine and methotrexate. And this year in one of the plenaries, in plenary 0001, presented by Dr. Batson, they showed a study in which they looked at 152 patients who were given either methotrexate at 15 milligrams per week or placebo, and that treatment was provided before the patients were started on their pegloticase, and then they were treated with pegloticase at 8 milligrams every 14 days by vein. They monitored their serum uric acid for this uptick that happens in the patients who are developing antibodies against pegloticase. That's an indicator that the pegloticase is no longer effective and a risk factor for developing adverse drug reactions against the drug. And they saw better survival, meaning no detectable increase in the serum uric acid levels in patients who had been pre-treated with methotrexate. They did not observe any transaminase elevations in that group. Here's the results of the study. The graph in this case is reversed from the one I showed you from 2020, where you can see the proportion of patients who failed. In other words, proportion of patients with 2 consecutive serum uric acid measurements above 6, above target, was much higher in the patients who were treated with placebo than the patients who were treated with methotrexate. So now I think in addition to mycophenolate, we have good data that methotrexate is another option for pre-treatment for making pegloticase more useful in clinical practice. So that's it. I would like to again close out by thanking the organizers for the opportunity to participate in Iracon. And I very much hope you're having a wonderful conference and as much fun as we had in Philadelphia, as you can see by a lot of familiar smiling faces in these photos. Again, I thank you very much for your time and welcome any questions.
Thank you, Professor White, for such an excellent description.